All right, thank you for coming to today's webinar, Trends in Vaccination Law and Judicial Challenges, presented by the Network for Public Health Law and the Act for Public Health. My name is Daniel Wacker, and I'm the Program Development Associate here at the Network's National Office, and I'll be your host today. Our moderator for today's webinar will be Darlene Huang-Briggs, who is the Deputy Director of the Act for Public Health campaign. And first of all, I just want to say we recommend using the Q&A function at the bottom of the screen, but we will also be answering questions that come in through chat. But we prefer the Q&A section because it keeps everything nice and organized. But now I'll pass it off to Darlene, who will lead us through the rest of today's webinar.
Great, thanks, Daniel. And welcome, everyone. We're glad to have you with us for a great panel today. I will introduce each of the speakers shortly, but before I do that, I'd like to share just a little bit about how the webinar came to be. As Daniel said, I help lead the network's contributions to Act for Public Health, which is a partnership of public health law and policy organizations. Next slide. So you can see those organizations here. We've got Change Lab Solutions, Temple University's Center for Public Health Law Research, Public Health Law Watch at Northeastern University, the Public Health Law Center, and the Network for Public Health Law. With funding from the Robert Wood Johnson Foundation, we support health departments and its partners in navigating changes to their legal authority to advance healthier communities for all. As you all know, though, the core mission for public health became especially challenging in the wake of pushback against the use of public health powers during the COVID-19 pandemic. Next slide. Act for Public Health, with the help of many of you and your organizations, began tracking a dizzying array of legal attacks on public health to help fight back against shrinking public health powers that are necessary to protect and promote community health. This includes rolling back public health authority in several ways, including limiting the use of vaccination requirements. You'll hear more about that in depth from your speakers today. I also want to take a moment to acknowledge that we recognize the hyper-politicized environment we're all living in right now elicits strong views on vaccine policy. Today's webinar is a professional public health law event, and while we encourage both discussion in the chat and questions for the presenters, we also have a zero-tolerance policy for misinformation and disinformation, and will moderate today's webinar accordingly. Act for Public Health has found that vaccine policy is an important bellwether for navigating changes to public health authority more generally, and we're excited to share with you this case study that illustrates the impact, both positive and negative, beyond the pandemic. Next slide, please. You can connect with us through our website, actforpublichealth.org, where you'll find a whole host of curated resources there, including information about what public health authority is and how we can more specifically help you. Next slide. Okay, I have just a few slides to ground us for the discussion today. This audience knows very well that vaccines save lives, protecting the health of individuals, families, and communities. Vaccines are also a great return on investment, preventing costly healthcare expenditures like hospitalization. Childhood vaccines, and school requirements in particular, have a wealth of evidence behind them in supporting healthy kids. Next slide. Still, we know heightened vaccine misinformation and disinformation, as well as a loss of trust in government institutions, including public health, during the pandemic have led to decreased vaccination rates in the US overall. Next slide. More parents of school-aged children, people who identify or lean Republican, and unvaccinated individuals believe the risks of childhood MMR vaccines outweigh their benefits. But I also think an important piece of the story here is the title of this Kaiser Family Foundation graph, that even among adults who haven't gotten the COVID-19 vaccine, a strong majority, 70%, say the benefits outweigh the risks. That gives me some hope, as does the ongoing work of my colleagues who you'll hear from next. Next slide. So I'm going to introduce today's speakers in reverse order. So you'll hear from Barbara Schneeman last. Barbara has been with Riverstone Health in Montana for nearly 20 years, serving in both volunteer and staff roles. She is Vice President of Communication and Public Affairs at Riverstone Health and the Executive Director for the Riverstone Health Foundation. Barbara is also a founding member of the Association of Montana Public Health Officials, the Montana Public Health Association, and the Montana Environmental Health Association Joint Advocacy Committee, now known as Confluence Public Health Alliance. She has been actively involved with the Montana legislative process for more years than she wishes to acknowledge, and she will share her story of hope that good policy can still triumph over politics. Next slide. Wendy Parmet is the Matthews Distinguished Professor of Law and Faculty Director of the Center for Health Policy and Law at Northeastern University School of Law. Professor Parmet is the author of over 100 law review and peer-reviewed articles, as well as essays in major US publications. Her most recent book is Constitutional Contagion: COVID, the Courts, and Public Health. It's hot off the press, has a fabulous cover, and we're really grateful Wendy could join us today on vacation. Next slide. You'll also hear from Maggie Davis, who is Director of State Health Policy at the Association of State and Territorial Health Officials, or ASTO. She provides law and policy technical assistance, support ASTO's Executive Leadership Forum and Legislative Liaison Peer Network, and oversees the organization's state legislation monitoring. She'll tell you more about all of that right after you hear from Katie. Next slide, please. Katie Moran McCabe is a lead law and policy analyst at the Center for Public Health Law Research at Temple University's Beasley School of Law. She conducts legal research and leads projects on a variety of policy areas related to public health. Katie co-leads the Center's Public Health Authority legislative tracking work, which is part of the Active for Public Health initiative. She has also led several housing-related projects for the Center, as well as the development of the Sentinel Surveillance of Emerging Laws and Policies legal mapping method. Katie, over to you.
Thanks, Darlene. Hi, everyone. Thanks so much for joining the webinar today. I'm going to start us off talking a little bit about some legislative tracking work that we've done at the Center as part of the Act for Public Health initiative. So I'm going to give a high-level overview and talk about some trends related to vaccine legislation. Next slide, please. So the work I'll be talking about today is an effort by Act for Public Health, along with our partners at ASTO and the Local Solutions Support Center. Next slide. So I want to start by giving an overview from the first year of this project, where we tracked state bills that were introduced from January 1st, 2021 through May 20th, 2022. Next slide. So for that time frame, we tracked bills on 6 topics and created a legal data set for each topic to identify key elements of the bills. So the topics are listed here in red on this slide. They are limits on public health emergency authority. So this mostly relates to limits on a governor or state or local health officials' authority regarding emergency orders. We also tracked bills reallocating public health authority, those that strengthen public health authority, limits on the enforcement of federal law, the regulation of specific public health measures, and public health preemption. So this slide shows the homepage for the data sets, where you can access all of them on lawatlas.org. And also, one of my slides at the end, there is a QR code that you can use to get directly to this site. Next slide. So big picture, there were 1,531 bills introduced in that time frame that I just mentioned, January 1st, 2021 through May 20th, 2022, that touched on one or more of these topics. And 191 of those bills were enacted into law in 43 states and DC. Next slide. So one of the categories that I just mentioned includes bills that address a specific public health measure, like vaccine measures, as well as mask measures, school provisions, business provisions. This slide shows the progression of those types of bills that were introduced last year. So that Red line at the top of the graph represents the vaccine-related bills. So you can see that that was by far the most commonly regulated type of public health measure. And then if you look at the table on the right, you can see the changes in the numbers of bills introduced on each measure. So at the top there for vaccine measures, the 501 represents the number of bills that were introduced between January 1st of 2021 and January 1st of 2022. And then as of May 20th, 2022, you can see the number of vaccine-related bills grew to 691. Next slide. And this map shows the states that enacted one or more bills related to vaccines as of May 20th of last year. So there were 66 bills enacted in those states that are highlighted on the map. So the states that are in yellow enacted one bill, and the states that are in purple enacted multiple bills. Some of these bills supported the use of vaccine measures. So for example, New York Senate Bill 4807 that authorized pharmacists to administer immunizations recommended by the CDC. And then some of these bills restricted use of vaccine measures. So there's Utah House Bill 63, for example, which requires employers to provide an exemption to vaccine requirements for people who have had a previous COVID-19 infection. Another example of a restrictive bill was South Carolina House Bill 3126 that prohibited vaccine mandates for state employees and school children. Next slide. Okay, so that was a bit about the first year of our project and what happened in the 2021 and 2022 legislative sessions. Now I want to go over what we're currently working on in years 2 and 3 of our project, and we're now tracking slightly different legislation. Next slide. So this data set shown here, we released this year, and it covers the same types of bills that we tracked previously, but the topics were combined into one data set instead of having 6 separate data sets. And this data set only includes bills that were enacted and are now laws. The data set picks up time-wise where the initial 6 left off. So those that I was just speaking about went through May 20th of 2022. This data set includes legislation that was enacted from May 21st, 2022 through May 22nd, 2023. Next slide. So on this map, you can see the states that enacted one or more bills addressing public health authority to respond to emergencies during that time frame. There were 37 bills enacted in the highlighted states here, so 17 states and DC. Next slide. Okay, so on this table, you can see the types of laws that were enacted during this time frame. So you can see that laws limiting public health measures were the most common. So there were 17 of those. And within those, vaccine measures were the specific measure most commonly regulated, with 15 of those laws limiting vaccine measures in some way. But then you can also see on that next line there that laws expanding public health measures were the next most common. So there were 14 of those, 8 of which related to vaccine measures. So some states working to restrict vaccine measures, but others working to support use of vaccine provisions. And then I also want to highlight here of the 6 bills that preempted public health measures, 5 of those preempted vaccine-related measures. Next slide. And then the last data set I want to talk about is actually one that is still being finalized. So it's not yet published, but we wanted to give you just a little sneak preview. This is a data set that we've created to track select vaccine-related bills that were introduced this year. So it's not limited to just those that were enacted. It includes bills at any stage of the legislative process. And it includes the types of bills that are listed here. So those that add or remove entry vaccination requirements, those that limit or expand non-medical exemptions for vaccination requirements, bills that reallocate the authority from a health agency to make determinations about vaccine requirements, and then bills that expand the scope of practice for vaccine administration. Next slide. So again, this is preliminary data that we're still working on finalizing, but wanted to just share some preliminary numbers to give you a sense of some of the vaccine-related legislation from this year. So far, 241 bills introduced from January 1st through May 22nd. And as of that date, 11 of those bills were enacted. You can see 14 had passed the first legislative chamber. 7 of those bills passed both chambers. 209 did not pass either legislative chamber, and 2 of those bills were vetoed. Next slide. And then this table just shows the breakdown of the types of bills, how many were introduced, how many were enacted. So you can see the most common type of bill introduced were those removing school entry vaccination requirements, 79 of those. But also want to highlight that there were a lot of bills introduced that would expand scope of practice for vaccine administration. So you can see 70 of those, 8 of which were enacted. So as I said, we're still working on finalizing this data set, but we should be releasing that soon. Next slide. Okay, again, so you can find these data sets on lawatlas.org. You can also scan the QR codes here to take you directly to the home pages for the data sets. And here's my email if you want to follow up. And that is it from me. Thank you so much.
Thanks, Katie. We're gonna kick it over to Maggie. I also just wanted to let folks know you don't need to enter your email address into the chat box. You can access the slides, the webinar recording afterwards on the network's website. And then if folks have questions, please make sure to enter those into the question and answer function of the webinar. All right, thanks, Katie, and Maggie, over to you.
All right, thank you. Good afternoon, everyone, or morning if you're on the West Coast joining us. My name is Maggie Davis. I'm the Director of State Health Policy at the Association of State and Territorial Health Officials. If you're not familiar with ASTO, we are a 501c3 nonprofit that supports, equips, and advocates for state and territorial health officials and their agencies, which is a kind of long-winded way to say that we support the state health departments and their associated staff. My team in particular supports a lot of the policy-related staff. So next slide, please. So my team runs 2 peer networks within ASTO. So we bring together the health agency staff that support the work between the health departments and the state legislature, so that liaison function. And we also support the attorneys that represent the health departments and kind of bring them together to provide both technical assistance and support, but also facilitate peer sharing, because we often see similar trends or issues arising in different states. And one of the best ways to support our members is to connect them with other people that have been in their seat or have faced similar challenges. So as a team, we provide technical assistance that could be helping connect health agency staff to another health agency, or doing some of our own research on a particular policy topic, or helping identify evidence-based public health efforts that our members can use. And we share that information both in kind of one-off technical assistance, as well as some learning opportunities such as webinars like this or other trainings. If you're interested in learning more, or seeing some of our kind of resources on different public health topics on our website, asto.org. We publish both an annual perspective series that looks ahead at legislation we're expecting to see in the states and legislative trends in the states related to public health, one of which is consistently on vaccines and immunization, which we're going to focus on today, and then some updates on emerging trends and policies within public health. Next slide, please. So one of the big kind of support efforts we have been doing since kind of mid to late 2020, our organization got some support from the Robert Wood Johnson Foundation to really start tracking legislative efforts in response to the COVID-19 pandemic. And in particular, we were looking at potential changes to state law that would affect kind of core public health authority, and to define what public health authority is. We're really looking at those core public health powers, or core powers that are often delegated to the health official or the health department to protect the public health and well-being of the jurisdiction. So that could be something like isolation and quarantine powers to prevent the spread of infectious disease, to support contact tracing efforts. So the kind of laws that would support the disease intervention specialists or contact tracers to do a case investigation to determine if there is an outbreak of a disease of any sort, so such as measles or another contagious disease. And then also the routine vaccination requirements. Kind of interrelated with that, during COVID-19, a lot of executive emergency powers were used to promote things like social distancing. So for example, there were governor executive orders to say encourage social distancing by limiting large mass gatherings. So we're really looking at any legislative trends that might change kind of either the scope of those powers or the procedure for exercising those powers. So for example, some legislatures shorten the period of time that an executive order could be in place without legislative review. And then the other piece that we really started to focus on was focus specifically on immunization. Some of these were directed particularly to COVID-19, but for example, expanding scope of practice to facilitate vaccine administration. We saw a lot of jurisdictions expand their scopes of practice for positions such as dentists, as well as podiatrists and a few other positions. And then also really looking at some of the state laws considering vaccine requirements, whether that be from the government, so whether there were changes to, say, school immunization requirements, or in kind of 2021, there was some consideration of policies where the government would require vaccines outside of schools and other positions, and then any sort of efforts that would prevent, say, private employers from requiring a vaccine. So we really were seeing kind of what was the changes happening in these areas of law, or these pieces of proposed legislation. And as Katie provided in the overview, because a lot of the legislative tracking we conducted has been informing the great work our partners at Temple University have done. There were a lot of bills introduced, but relatively few were enacted into law. And I highly encourage you to go to the resource Katie pointed you to see some of those examples that we flagged of some of these proposals that were enacted into law. For today, though, I want to focus on this most recent legislative session, so 2023. There was a lot of work and shifts that happened between 2021 and 2022. So there are resources out there where you can kind of see what some of those shifts have been. And again, the Temple resource. But for today, I'm really trying to focus on kind of what is the current landscape we're seeing 2023, where we're really focusing on some of those immunization efforts. So next slide, please. So far during the 2023 legislative sessions, there's been a few key themes that our team has noticed related to immunization specifically. And in relation to our members, which are the health officials of the public health agencies, we're looking at some of the proposals that consider maybe shifting public health authority or public health powers related to vaccination. So for example, in the majority of states, the immunizations that are included in the routine child immunization requirements for school entry are established by rulemaking under the state health agency. So that tends to be informed by subject matter experts from public health. A very small number of states actually delineate which vaccines are required in state code. We did see a few bills this session that was considering shifting that authority. So say maybe taking that authority away from the public health professionals and shifting to a delineated list of vaccines in the legislature or in legislation or in a statute. And then there was also whether or not a governmental actor could establish a COVID-19 vaccine requirement at all. This is not as prevalent of a proposal as we saw in 2021 or 22. A number of states did enact laws related to that during those sessions. But those are still some proposals that we've seen in the 2023 session. Another area that we were really focused on is those school entry requirements for routine childhood vaccinations. And I'll get into a little bit more detail of some of the kind of conversations that happened in state legislatures and within state government over this past year on the school entry vaccine requirements in a little bit. And then again, that expanded scope of practice to increase the vaccinator workforce from 2021 until May of, well, it's still now in effect. But at the height of the COVID-19 pandemic, we had a lot of support in the vaccination workforce by the PrEP Act declaration. So the federal government, through the PrEP Act powers, had provided a lot of liability protections for healthcare practitioners to administer the COVID-19 vaccine, as well as some of the seasonal flu vaccines. That PrEP Act was most recently amended to extend those liability protections through, I believe, December 2024. But with the kind of the end of those liability protections coming on the horizon, a number of jurisdictions are really re-examining their scope of practice laws to make sure that you have a robust vaccination workforce. And one of the main professions we've seen that expansion in has been pharmacists. During the COVID-19 vaccine rollout, there was a great success with partners in kind of pharmacies across the country to really increase access for people to receive vaccines and to, kind of expand who is able to provide a vaccine safely. So a number of jurisdictions are really reassessing that scope of practice of which healthcare professionals can provide a vaccine. And then we are seeing a number of bills that are looking at vaccine injury studies or reporting. And these bills kind of range for a number of different issues. For example, there are some efforts to have the health department establish a system that would require publication of adverse vaccine events separate from the federal vaccine adverse event reporting system. There hasn't been a lot of movement on these bills, but we have seen quite a few considered. And there were some of these bills that were enacted for example, there was this wasn't a bill. So there was an executive action in Florida that announced that they were doing research in some potential vaccine injury. So we are seeing state governments really starting to look at if there are any concerns on vaccine injury studies or reporting. But again, we haven't seen a lot of bills enacted from the legislature, or just not a lot of movement on that policy issue. So next slide, please. I want to highlight just two states. Katie had mentioned briefly kind of the preview of the upcoming data set for 2023, that there were two bills related to vaccines that were vetoed. And I did want to just kind of share what those bills were and a little bit as to why. I'm going to talk about three vetoes. So I just gave Katie an updated data set yesterday. So her slides are accurate as the information she had. Two bills were vetoed out of Arizona. So during the 2023 legislative session in Arizona, we identified at least 8 bills that were related to vaccines. 2 of those bills passed both chambers, reached the governor's desk, and the governor of Arizona opted to veto both bills. So the first bill would have prohibited adding a vaccine under an emergency use authorization to the school entry vaccination requirements. And in the governor's veto letter, the governor of Arizona really focused on a concern that such a bill would undermine public trust in vaccines as approved by the FDA. So again, emergency use authorization does provide a level of support from the Food and Drug Administration. I would also like to note, by our understanding and tracking, there were not states that passed laws to require any EUA for a school vaccine. We really just didn't see that happen in a lot of jurisdictions. So it really, the governor decided to veto that bill, really in an effort to make sure that we are still supporting and showing trust in the FDA process of establishing that vaccines are safe and effective. The second one was a bill that would have required employers to recognize religious exemptions for COVID-19, flu, and other vaccines under an EUA. And the governor's veto in this case was really noting that there were other laws already in place in the jurisdiction that got to the same concern. And the governor found that the potential fine and threat in this bill would be potentially too damaging to small businesses. So in this case, the governor also vetoed that. Next slide, please. And then the third vetoed bill came from the state of Louisiana. So this session so far, Louisiana's legislature considered at least 7 vaccine-related bills, with 2 bills passing the chamber and the governor vetoing one. The first bill that the governor signed prohibited nursing home facilities from requiring visitors to submit proof of vaccination. We saw a lot of legislation, particularly 2021 and 2022, around around visitor requirements. So making sure that if someone is, resident of a nursing facility, that visitors are able to come see them, and that the facility guidelines are supportive of that. And what this bill does is says that a private facility or a facility that is a nursing home facility cannot make it a rule that you must show proof of vaccination to visit your loved one that's in the facility. The second one that was vetoed was a little confusingly written. So this was a requirement that any school district that was communicating about their routine school immunization requirement must include language about exemptions to the requirement. So under Louisiana law, there are both medical and non-medical exemptions, and they have both religious and philosophical exemptions. And a parent can exercise those exemptions through written word to the school. What this law would have done would have required any sort of communication, kind of reminding parents that there is an immunization requirement to include the specific verbiage from the statute in that communication. The governor ended up vetoing this bill, citing that it would undermine faith in the public of vaccines, but also to reiterate that there was no change to the law. There are still the medical and non-medical exemptions in Louisiana. Next slide, please. So those were 2 jurisdictions. And again, these were just highlighted because those happen to be the jurisdictions that have had bills vetoed this year. There's been a lot of consideration and legislation across the country on vaccines this session. And as we as public health professionals and our organization that is directly supporting the health departments have really seen the hard work our members have put in to make sure that they are educating legislators and really trying to build key relationships to continue public support for vaccines. And in particular, making sure that we kind of keep the public health successes that we've seen in vaccine policy around things such as school and daycare vaccination requirements. So I have on the slide a quote from Claire Hannon, who's executive director of the Association of Immunization Managers, that she said a few months ago that it really is a necessity to protect children in our communities to continue supporting these laws that provide kind of routine school immunizations. And understanding that there are voices out in our jurisdictions that are expressing concerns. And so what we've been doing is really working with our members to make sure they have access to evidence-based information and kind of thinking through how to build and foster those relationships. And wanted to kind of highlight a few examples of successes we've seen so far this session. So for example, the state of West Virginia for years have had very strong vaccine laws. So they have only medical exemptions to their school immunization requirement. So they do not have a non-medical exemption for routine school immunization. And that has been a pretty big success for that jurisdiction. Like many jurisdictions this session, they saw proposals that would consider maybe adding a non-medical exemption or altering their status. And the leadership within the West Virginia Health Department was really successful in building relationships and educating legislators to make sure they understood what the successes that West Virginia has already seen. in particular, around the time of the session, one of their neighboring states had a pretty large measles outbreak. And our membership and the leaders of that health department were able to talk to key legislators and explain, like, it can't say direct causation, but we are very fortunate as a jurisdiction to not have had, an outbreak of measles as we're seeing in this neighboring state at this time. That takes a lot of effort and a lot of time and resources, but is critically important. And I know a lot of our members are thinking very thoughtfully of building those relationships with legislators as well as the public. We're also making sure to kind of bring together some of the partners, some of which you've seen on this call and some others across the nation, to make sure that our members are provided information on existing vaccination programs and what are the national best practices. And that sort of resources our members have been able to really use to help inform these conversations with policymakers so they know what the successes of vaccine policies have been. And then in a little bit, you're going to hear from one of these kind of grassroots advocates. It has been incredibly beneficial to have the vocal support of communities in these legislative discussions. So we've had a number of our members share that they've had success because there's been, voices from the community of people that have really benefited from strong vaccine policy, as well as people that have unfortunately developed vaccine preventable diseases because they were not appropriately immunized. And hearing those stories have been incredibly powerful. That, I think, is all the time I have. So I think I'm going to turn it back over to you, Darlene.
Fantastic. Thanks, Maggie. We have Wendy Parmet up next. Wendy, if you can come on screen and unmute yourself, that would be great. All right.
Thank you. Can folks see me?
We can see you and we can hear you.
Okay, sorry about that. Having a little bit of technical difficulty here. So thank you so much. Next slide. It's really a great honor to speak with you today. I want to thank all of our partners in the Act for Public Health Partnership. I am coming to you today speaking in the capacity of working with a group called Public Health Law Watch, which is a sort of loose consortium of around 100 law professors and professors at schools of public health and some practitioners who are concerned about and want to think about using law to protect public health and promote health equity. So I'm coming in that capacity, and this work I am doing comes with the support of the Change Lab Solutions and the Robert Wood Johnson Foundation. So next slide. So our team has done several studies tracking litigation, analyzing litigation, a whole wide range of litigation having to do with public health since the start of the pandemic. And I'm not going to talk about all of these now, but the QR code on the slides is for a paper we had out earlier this last winter in the American Journal of Public Health, my co-author Faith Kallick and I, where we looked at over 1,000 decisions issued by courts during the pandemic that discussed public health authorities. I want to be clear, we were looking at decisions, not cases. So in some cases, there would have been multiple decisions. Some of these decisions were later vacated or mooted. But our goal was to sort of look at what judges were saying. And you can see that study through the QR code. We've also been updating, looking at vaccine cases, really from the time that study ended on July 1st, 2020 to relatively recently. I want to also add another disclaimer. I guess I could add a lot of disclaimers, but we're not looking at contract claims. We didn't look at tort claims, IP claims, claims seeking release from detention. There were lots and lots of those early in the pandemic. We didn't look at claims under the ADA. We didn't look at Title VII claims, although I'll talk a little bit about that. labor law disputes or claims in tribal courts. Next slide. To give you just a brief flavor of what we found, again, well over 1,000 decisions, that number should be quite much higher, but 300 of which talked about vaccine mandates. And in the vaccine decisions that we looked at, lots of different claims were raised. They were due process claims, equal protection, free exercise, scope of authority. I'll talk more about that in a minute. And claims brought under the Religious Freedom Restoration Act, federal and state versions of that act. I'll talk more about that in a minute. There are also some other random claims for some First Amendment free speech claims. So there's been a bunch of different claims. Next slide. So I always like to start at the beginning and start where we, where were we in vaccine mandate law back in 2020, if we started all of this? And I'd like to say that there was a three-legged stool that formed the foundation, and it was a very sturdy foundation for the ability of a state or local jurisdiction to require vaccination. And I'm talking about mandates here. I'm not talking about compelled vaccination, forcible vaccination. I'm talking about mandates such as the kind we've had in this country since, well, early 19th century. The major precedent, right, that many of you probably know is Jacobson versus Massachusetts. That's a 1905 decision from the US Supreme Court, which held that in Cambridge, Massachusetts law, which required vaccination of everybody against smallpox, right? That's the vaccine we had back then. For everybody in Cambridge to be vaccinated against smallpox or pay a fine, it was a criminal violation, was constitutional and didn't violate the due process clause. Jacobson is the foundational case. It's very important because it established that that the Constitution's due process clause does not prohibit vaccination mandates. I should also say it talked a lot about deference to the states and why, right, states had the capacity and self-preservation to mandate vaccination. There's a lot of different aspects about Jacobson. It also hinted, right, that maybe medical contraindication, exemptions would be required. There's a lot in that case. We could talk more about it in Q&A. It's worth noting two other things about Jacobson. First, although it was the foundational case, it was hardly the first. There was a lot of state law pre-Jacobson ruling the same way going into the 19th century. Secondly, Jacobson was not decided under the free exercise clause of the Constitution. It was not, in that sense, technically a religious liberty case, even though Jacobson himself had religious objections to vaccination. He was a pastor. It wasn't a religious liberty case because there were no such religious liberty cases back then. The Supreme Court had not applied the free exercise clause of the First Amendment to the states and only applied to the federal government. Despite that, there's language in Jacobson about religion, and the Supreme Court in the years after Jacobson was decided, after the Supreme Court applied the free exercise clause to the states, kept citing Jacobson for that point, right? And as if, well, there can't be a free exercise claim here. And that was pretty well established. The second leg of the stool is from 1990, right? 85 years later, Employment Division versus Smith, a opinion by Justice Scalia that held that facially neutral rules of general applicability that don't target religion are subject to the rational basis review. That is the most deferential, easiest form of judicial review for a state to pass. And so that seemed to just solidify the Jacobson idea, right, that had been going on, that's vaccine laws that simply say everyone must be vaccinated unless they have a medical contraindication doesn't violate Jacobson. And if you thought it violated free exercise clause because maybe Jacobson didn't apply technically, well, Smith seemed to make it clear. But the third leg of the stool, and very important, is a case a few years after Smith called Church of Lukumi Babila Aya versus Hialeah, which made clear that Smith doesn't apply if a state targets religion, if there's evidence that the law was passed based with animus towards religion, right? So a state does not have to offer a religious exemption, but if a state creates a vaccine mandate law, and we could come up with some interesting hypos that really seem to target one particular religious group, that would be unconstitutional. With those backgrounds, almost all traditional public health laws, including vaccine mandates, including childhood vaccine mandates, passed constitutional muster. But almost all state, not all, but most state childhood vaccine laws include the possibility of religious exemptions. There is a federal statute, the Religious Freedom Restoration Act, which I'll talk more about, that requires strict scrutiny, this higher form of judicial review, where the government has to show that the law is the least restrictive means of achieving a compelling state interest. That law applies to federal statutes, so that was applied to federal mandates. And then Title VII requires that private employers accommodate religious objectors' employees. So there are a lot of statutory and sub-constitutional protections for people with religious objections. Next slide. Next slide. Thanks. Okay, so that's where we were in 2020. And then, right, the world shuts down and everybody remembers where they were, right, when the NBA stopped, canceled its season, and governors throughout the country and all states started issuing a whole bunch of different orders, limiting gatherings, closing businesses, restricting businesses, etc. People, not surprisingly, this is America, this is what we do, they ran to court to challenge these orders. Overwhelmingly, state orders were upheld. And again, I will refer you back to our AJPH article that talks about that. With a few exceptions for some free exercise cases, particularly coming out of the Sixth Circuit. But initially in the spring of 2020, the Supreme Court was, the best way to put it is, it was either supportive of the constitutionality of the orders, or at least it didn't feel that these constitutional claims merited judicial intervention. And in two cases, one in the end of May of 2020 and one in July of 2020, the Supreme Court refused to issue an injunction and block some orders, one limiting religious worship, one from California, and the second one from Nevada. The first case, South Bay United Pentecostal Church versus Newsom, it was decided from 5-4. There's no majority decision, as there usually isn't when the court just simply decides not to take a case. But Chief Justice Roberts, in concurring, cites Jacobson for the point that the Constitution principally entrusts health decisions to politically accountable officials. And he also said that the state appeared to treat worship similarly to comparable secular activities. In a dissent, Justice Kavanaugh said the state did not treat worship comparably to secular activities. In the second case, the only thing I want to say about that is that in an interesting, turned out to be a prescient dissent, Justice Alito said that Jacobson simply was not relevant to free exercise cases. Next slide. In November 2020, the Supreme Court turns and Justice Amy Coney Barrett joins the court. And almost immediately, we see a dramatic change in the Supreme Court's views about religious liberty challenges to public health COVID orders. And the first case was Roman Catholic Diocese versus Cuomo, which had to do with restrictions on worship in COVID hot zones as they were defined by the state. The court held that strict scrutiny was required because some secular activities, such as acupuncture centers or retail establishments, were not subject to the same restrictions as religious activities. And that no deference was given, and I should say the court didn't say this, but it's clear that the court gave no deference to health officials on why they thought that acupuncture and religion was comparable. The court just takes that at face value. The court also found that the order could not survive strict scrutiny, that there was no, the state could not show that the order was the least restrictive means necessary to protect the public's health. Then in April, and a whole bunch of other decisions happened along the way. I'm not going to talk about all of them, but in April of 2021, this court in Tandem versus Newsom blocks the California law restricting the number of people who could worship in private homes, even though worship is not mentioned. Court says, well, but again, retail establishments, train stations are open, so you've got to let people come into a house to do Bible study. And then in June of 2021, a non-COVID case, Fulton versus City of Philadelphia, the court said that whenever a state agency jurisdiction has the discretion to provide an exemption for any reason, the failure to provide a religious exemption triggers strict scrutiny. So this dramatic change in free exercise clause doctrine between November of 2020 and June of 2021. Next slide. This makes a big deal difference for vaccines, okay? Because even though those cases I just talked about weren't vaccines, the free exercise claims are not limited to vaccines, nor are they limited to activities that contradict the tenets of any major religion. Anybody can have their own religion. Anybody, if they sincerely believe that a law burdens their religion as they understand it, even if it's a religion of one or a religion of two, can bring a free exercise claim. And courts generally defer to plaintiffs' contentions that a regulation actually burdens their exercise of religion. So this has paved the way for free exercise and reefer challenges to vaccine mandates using this new jurisprudence, even though no major religion opposed vaccines. And even though many of the religious exemptions, at least some, I should say, some of them were founded on questionable science. Next slide. So here's the way some of these claims go, right? Every state that has a vaccine mandate, childhood mandate, COVID mandate, they always had medical exemptions. Indeed, as I said a few minutes ago, Jacobson seemed to say you have to have medical exemptions, right? If the vaccine's person's at a particularly high risk for a vaccine adverse reaction, you have to let them opt out of the vaccine. Okay. The question then came, and litigants argued, well, if you exempted people who have medical contraindications, but not people who have religious objections, are you treating religious exemptions unfairly as compared to medical exemptions, right? Isn't this like allowing acupuncture but not worse? That's the argument. And several courts of appeals just said, no, that's, medical contraindications are not like religious exemptions. Medical contraindications are to also promote public health. Religious exemptions are not for promote public health. In the fall of 2021, the First Circuit made that argument in a very thorough decision in a case called Doe's versus 1-3 versus Mills. It refused to block Maine's mandate for healthcare workers that had a medical objection for a COVID vaccine mandate, but not a religious exemption. The case went to the Supreme Court. The court chose not to take the case, but in a dissent, Justices Gorsuch, Thomas, and Alito said that the plaintiffs were likely to win on the merits. They disagreed. They felt that these exemptions were comparable, and they also concluded that controlling COVID, although it remained a compelling state interest, they questioned for how long it would and whether the mandate was necessary for it. Next slide. So that's where it stood. But other cases challenging Maine's mandate have continued to percolate. And in a related case, Lowe versus Mills, the First Circuit just a couple weeks ago seemed to change its thinking on the matter and ruled that the question about whether medical exemptions and religious exemptions are comparable warranted a trial. And so kind of pulling back from their language and their reasoning in 2021, there are some technical reasons about why this isn't overruling the case. These are at different postures in the litigation, but the court has said that a trial needs to go forward on the comparability issue. And they certainly seem to walk back some of the reasoning that they had come to in 2021. Next slide. Okay. I mentioned the Religious Freedom Restoration Act, and that there are federal and state Religious Freedom Restoration Act cases. The federal statute, which is very similar to the ones in most states, federal statute says that strict scrutiny is required if a federal law burdens religion, substantially burdens religion. Next slide. And we have seen many courts use RFRA to challenge federal mandates. And one particularly interesting one, the Fifth Circuit ruled that the federal mandate of the US Navy SEALs violated RFRA. The Fifth Circuit issued an order compelling the Navy to deploy unvaccinated SEALs. The Supreme Court narrowed the order, but didn't question the underlying reasoning of a RFRA violation. Next slide. I want to very briefly talk about the major questions doctrine and the scope of statutory authority. So I've been focusing on religious claims, but another claim is, does the jurisdiction, does the agency that issued the mandate have the authority to do it? These cases have now come under the so-called major questions doctrine at the federal level, where the court is ruling that if something is a major question, whatever that is, the government cannot issue the ruling, the requirement, unless Congress has explicitly authorized it. The several circuit courts have struck many of the federal vaccine mandates under the major questions doctrine, including mandates for federal contractors, for federal employees, for Head Start workers. The Supreme Court struck mandate to be vaccinated or have a test and masking policy by OSHA under this doctrine, but it upheld the healthcare worker mandate issued by CMS. Next slide. Okay, just going to skip this one for time. Next slide. Okay, just briefly, I mentioned Title VII cases. Here's what I want to say. Until very recently, the Title VII's requirement that employers accommodate religious exemptions was really not very onerous requirement for employers. A de minimis burden standard was applied. Just the end of June, the Supreme Court issued a new Title VII case, not a healthcare case, called Groff versus DeJoy about the Postal Service, where an employee had a religious exemption, a religious claim for working on the Sabbath. The court changed the standard and said it has to be something more than de minimis. Employer has to show some kind of substantial increase in costs or burden. We don't fully know what that means or plays out, but expect to see more Title VII vaccine mandate cases, especially in the healthcare sector, where workers have traditionally, many workers have been required to be vaccinated. Next slide. I know I'm at, go back one. I just want to say, we're seeing this apply now to all of these changes in the doctrine to childhood vaccines, Last fall, the Second Circuit overturned a lower court summary judgment order in a challenge to a healthcare order that barred unvaccinated child from attending school in a measles outbreak. This really differs from where the Second Circuit had been earlier. And then just recently, a court in Mississippi ruled that the state had to have religious exemptions. So more than a century, well more than a century of law is now being questioned. Last slide. So first takeaway, we've entered into a world of doctrinal instability regarding religious exemptions and the scope of authority. The ability of governments to impose vaccine mandates, which have been going on since the 1820s, is just now uncertain. Okay, complicating the picture, mandates with or without religious exemptions can be successfully challenged and are being challenged. It's constitutionally and litigation-wise risky for states to withhold or deny exemptions to those who seek them on religious grounds. Most mandates are still being upheld, but the future is certainly uncertain. And I'm happy to talk more about implications in the Q&A.
Great. Thank you, Wendy. And we'll also get a chance, I know, hearing what's happening in the courts can be some of the most depressing things for me personally. So we'll have some time in the Q&A to talk about some policy suggestions, sort of given where the courts are at right now. And a reminder that we will have the slides and the recording posted on our website. So I know Wendy skipped through a slide. You will have ability to go back and see what she wanted to talk about there. And we can also do some of that in the Q&A. All right, Barbara, last up, thank you.
Great, thank you, everyone. I'm very pleased to be a part of this esteemed panel and wanted to let you know that I'm pitch hitting today for my colleague who is the Executive Director of Confluence Public Health. She is actually having a baby today, and she wanted me to convey to you all that she thinks vaccine policy are very, very important in helping to protect the health of her child. So with that, I just want to let you know, Riverstone Health is the local health department in Yellowstone County, Montana, which is the most populous county in the state of Montana. Montana only has slightly over 1 million people. So what I will share with you today are kind of what we've been doing with Confluence Public Health Alliance and our legislative session. So the next slide is the Confluence Public Health Alliance is really an umbrella advocacy organization of 3 different trade associations, if you will. AMPA, which is the Association of Montana Public Health Officials, has membership of about 56 counties. All of those are Montana counties, and then 8 tribal health departments. MPHA, or the Montana Public Health Association, is an individual member organization with about 500 members. And Montana Environmental Health Association is made up of about 100 sanitarians throughout the state. So really, you'll see our mission and our vision there, but we really want to make sure that we're supporting the work of local health departments and make sure our state policies are, and funding, importantly, support the work of our members who protect the health of their constituents across the state of Montana. So next slide. I just wanted to show you a little bit about our structure. So you'll see Confluence Public Health Alliance in the middle there. We have a policy and advocacy committee. And you will see that we do have a staff. We have an executive director and an operations specialist, which we feel very fortunate to have. Confluence is only about 1.5 years old, but we've been doing this work for a really long time. You'll see that we also have a lobbyist, and we also have representation from our state health department. And you'll see technical assistance, APHA, Change Labs, Acts for Public Health, the Network for Public Health Law, and others. We also are very involved with coalitions and partners. Wanted to pull out specifically Montana Families for Vaccines. They're a very new group. They just got started about a year ago, and they've been a really great partner in this work. But you'll see that we also have Friends of Public Health, which includes our Association of Counties in Montana, the Montana Medical Association, the Montana chapter, the Academy for Pediatric Physicians, and others. So wanted to let you know that just because Confluence is 1.5 years old, that doesn't mean that we've only been doing this work for 1.5 years. Way before there was Confluence, the 7 most populous health departments pooled resources and have always had a lobbyist at the Montana legislative session for more than 20 years. So it's work that we've been doing across the state for a very long time. So with that, next slide, I wanted to tell you just a little bit about the Montana legislature. Unlike the vast majority of legislatures in the country, our legislative session is a 90-day session every other year. I believe Texas is the only other state that meets every other year, and we meet in odd years. So we just got done with a 2023 legislative session, but we do have 100 members in the House of Representatives. They're elected to 2-year terms, and they can serve up to 4-year terms, or up to four times, so 8 years. 50 members in the Senate elected to 4-year terms, and they can serve 2 terms, so again, 8 years. This doesn't preclude them from switching chambers. So a member of the House, after they're termed out of the House, they could decide to run for the Senate, and the same with the Senate wanting to run for the House of Representatives. And they can continue to do that pretty much indefinitely, because in Montana, we do have term limits. And then you may be thinking, okay, well, how in the heck do you guys get anything done within 90 days? And if you only meet every other year? What we have is interim committees where work does get done. And I want to talk about that at the next slide. So just to let you know also, when I was looking at the legislative makeup of the Montana legislature, because these individuals only serve 90 days every other year, by no means are they professional lawmakers or policymakers. They typically have other jobs or they're retired. The legislative staff in Helena is not their personal staff. They share staff. And so a lot of work happens there. But right now, our legislative landscape, we have a Republican supermajority. But we also, within that Republican supermajority, we have something called the Solutions Caucus, or those Republicans who are more moderate. And then we have a partisan legislative interim committee, which is the first time we've ever done this in the state of Montana. So usually our interim committees have been balanced between House members and Senate members, and Republicans and Democrats. And really the idea is during the 18 months between legislative sessions that they get together and they really study issues and they learn about them in an in-depth way. And they are nonpartisan, so that by the time the legislature comes around, what happens is that those bills that were presented during the legislative interim, they have a greater opportunity of passing the legislature and actually becoming law. But because we have a partisan interim committee system now, we'll just have to wait and see what happens in the session in 2025. Our legislative interim committees are just actually now getting started. But also, with regard to term limits, what we've found is that if policymakers don't want to pretend to be professional legislators every other year for 90 days, they really have an opportunity, they have a really less time to make an impact from a policy perspective. We're also finding that because of term limits, institutional memory has really been diminished. And so we're finding that things that had been talked about 20 years ago are being talked about again. And so sometimes it could be a little frustrating, but because of this, our trusted lobbyists, those people who are in the halls, walking and talking to legislators become very important. And I'll share some information with you kind of towards the end here. But the next slide, please. To talk more about the 2023 Montana legislature, just want to let you know that there were several kind of vaccine related bills that were proposed during this last session. But immunization policy or vaccination policy has been on the legislative agenda for more than 20 years. You know, we had a governor at one time who believed that there was a connection between vaccines and autism. And, you know, but what we're seeing more now is kind of this whole personal freedom, vaccine injury, you know, like our other panelists have talked about. So the good news is that we have two bills, Senate Bill 450, which failed, and House Bill 954, which also failed. So in Montana, we do have a existing medical and religious exemption, but Senate Bill 450 wanted to add a philosophical exemption as well. So we really kind of positioned that as personal choice, small businesses, and really an unfunded impact on counties or local health departments for outbreak control or investigations. Daycare facility immunization requirements, that was a bill that also failed. The Child Care Coalition, they were really very concerned about this. They came to the forefront to help defeat this bill. What did pass, though, was House Bill 715, which required all schools to communicate the availability of immunization exemptions. And they were to provide, or they're providing links or copies of forms for people to do. But it also, from a public health perspective, requires parents to sign off before giving their immunization or the children's immunization info to public health. So really, this is detrimental to public health from the standpoint, if there is an outbreak situation, we can't go immediately and look at school records to find out who's immunized and be able to, you know, quarantine or isolate children as the case may be. So up until 2021 was, we were pretty successful in making sure that immunization policy stayed stable in the state of Montana. What changed in 2021 is that we got a new governor. So while we have had Republican majorities, conservative majorities in the past, there's been a Democratic governor who we've worked pretty closely with to veto different bills. The next slide, please. So really, we're looking at a situation which is very partisan and very political in the state of Montana. So what's really important is that our public health lobbyist partners with other lobbyists are in the Capitol. So really what happens is there's a lot of hallway deals, a lot of things that happen during the legislative session that unless you were right there in Helena seeing what's going on, from a grassroots perspective, you don't have the opportunity to really weigh in and know which strings are being pulled in which direction. So really that's important for the public health lobbyists to work with our executive director of Confluence, because our executive director and operations specialists, they activate a grassroots network. They will go ahead and they'll send out calls, action alerts for us to provide calls, emails, or when there's hearings coming up, definitely provide testimony, but also making sure that it's the right person or the grass top. So it's the person who has the relationship with the key decision makers who are making that those trips to Helena. What's super important to remember is that public health may not always be the very best messenger. You know, it could be daycare providers, it could be business owners, small businesses. So just really knowing who your target is with the message and the right messenger to reach that person. So, you know, we talked a lot about employer liability and the rights of employers. We talked about childcare accessibility for working families. In the state of Montana, we have a very, I guess, detrimental situation in terms of childcare. It's really, really difficult to find good childcare here. So we really wanted to make sure that people understood that. And then also, again, the impact of outbreaks. We've had a couple of chickenpox outbreaks, but thankfully no measles, but we've been really kind of talking about those things. So the next slide, I have some closing thoughts for you. Or actually, I guess I don't. Administrative and interim strategy. I'm sorry, I got ahead of myself. We're going to have a hearing or a legislative rule process that'll be coming up here pretty soon that will try to do what one of our bills couldn't do in terms of revising daycare immunization. So we're going to keep a really close eye on that. I talked a little bit about the interim committee engagement. We have several different committees, and we really want to make sure that we are monitoring those right committees and getting the right people on panels. And then importantly, membership engagement and grassroots relationship building. So the next slide, it will be my closing slide. So some closing thoughts. I just ask you all to pay attention who's running for office, whether that be at the local level or state level. Previous elected officials or appointed officers actually end up being legislators at some time, or they do in our state of Montana. Find out what the motivating issues are and really look at the relationships between the lawmaker and other people who could be influencing those individuals. So for instance, look through campaign finance reports, find out who's giving to that candidate. If there's a policymaker that you want to get to know a little bit better and they're in your district, invite them for a site visit. Have them look at behind the scenes, look at your different programs and services, and really kind of build that relationship. Share information with your network across the state, and always importantly, ask for technical assistance. We have some amazing speakers and groups represented on this conference today, and I would encourage you all to reach out to them for assistance, because if you don't know the answer, I'm sure that someone else does. So in closing, thank you very much for your time here today, and it's a pleasure to be a part of this webinar.
Thank you, Barbara. That was some really helpful practical takeaways. If we could have all the speakers come back on camera. We've got about a little over 10 minutes for some questions. Barbara, if you don't mind, there is one specific question to Montana's position on collecting vaccination data from schools. Do you know what the state's position is?
Okay, I'm sorry, for some reason my video isn't working now, but
yeah. We can hear you.
Yeah, good. Okay. Before this legislative session, they used to be able to get all of that information. And I'm not sure, based upon the actions of this last legislature that ended at the first part of May, what that is going to look like from a practical experience.
Okay.
So I think we're still kind of waiting for some guidance from the state health department to go to schools.
Okay. One of the other questions we get a lot too, Barbara, how does the coalition sort of prioritize what issues they're going to work on and what policy positions they might be pushing? I'm guessing some of it is reactive to what's coming up, but can you give folks a little bit of an insight into how y'all are doing that, or how you might suggest others go about doing it?
Yes, so what we've been doing in terms of looking at what issues that we're going to follow, because as we all know, we can turn any issue at all into a public health issue. Just ask us, we'll do it. But we also know that we have very limited resources. And so what we tend to look at, again, are those interim committees. What were the big issues that those interim committees were talking about? And what is the role for public health? We really kind of take a look at where do we have a unique opportunity to add value to the conversation? And also, where are there unique relationships with those decision makers who are going to make a decision that will impact the health of Montanans? So we typically have a very broad agenda that starts out at the beginning of the session. And as the session goes on and we take a look at what bills are popping up and what things may be really kind of hot on the agenda. So for the last couple of years, obviously it's been public health authority. It's been immunizations. Those things tend to take precedent over, well, more than a few years ago, it's been raw milk. And so that issue was decided for us. And so we just kind of move along. But the key really is to be flexible. While you may have a wonderful template, just making sure that you're flexible enough to realize that just because it's your agenda, it may not be the legislator's agenda.
Thanks, Barbara. Wendy, I know we had a little bit of a brief conversation about a recent piece that was published in JAMA. I can't remember what it stands for now, that focus on vaccination mandates. And I'm putting the link to the article in the chat here for everybody. But at the end of the article, the authors clearly prioritize protecting school entry requirements, as well as mandates for health care and long-term care workers. But they also acknowledge that population-wide mandates are just, as you've described, all of the reasons why, very legally fraught at the moment. So they suggest where mandates are not feasible, government can boost vaccine uptake through evidence-based nudges and supports. Can you comment a little bit on the article's policy suggestions and sort of where you might differ or agree with the authors of that piece?
Sure. I don't think there's a lot of space between me and the authors, all of whom I have worked with in the past and who I think really respect their work and their wisdom on this. You know, mandates, there's always two questions about mandates. One is it legal? And the second one is it a good idea, right? And what I was talking about was the shifting legal landscape and the fact that the legality of mandates, which previously, pre-2020, had felt pretty certain. I mean, there are some exceptions that I won't go through, but it was really, really about as solid as we have anything in the law, has now become uncertain, unsettled, contentious. That means that the imposition of mandates is more likely to provoke litigation, and the outcome of the litigation is harder to foretell. And it seems to me that that has to weigh into the question or to the calculus of should you do a mandate, right? Because you got to do the cost benefit. What are the benefits of the mandates? We know that mandates can increase vaccination rates for diseases like measles in particular, right? There's solid evidence of the efficacy of mandates. But we also know mandates can spark backlash. And now we know that they can spark litigation and that the litigation could go potentially in different directions. And so you got to be careful, right? I mean, just because you can do it doesn't mean you should do it. And I think what they're saying is, you know, focus on where we've got the best evidence, where we have the best track record. That's childhood vaccines. Focus where the need is the greatest, where you are perhaps most likely to survive a compelling state interest test. Healthcare, really important. You know, patients are vulnerable. They can't take care of themselves. We have a long history, and be wary of pushing the envelope with mandates because we are now in this uncertain domain. So I agree with them. You know, in terms of other ways of getting high vaccine rates, there are a lot of different policies out there. Many have been tried. You know, Frankly, I don't think there's a lot of evidence that many are as efficacious as mandates have been previously, but it may also be in this new litigation environment that mandates are less efficacious. So other policies may look like better options given the litigation uncertainty with mandates.
Thanks, Wendy. And then can you provide clarification about one of the cases you talked about, Massachusetts versus Rockland County? Did it find an unvaccinated child had to be allowed to attend schools even though there was a measles outbreak?
No, and it's not Massachusetts. It's MA is the child.
MA.
Excuse
yeah.
me. I'm from Massachusetts. No, I should be clear. It sent the case back for trial. Okay, it did not. It's not a final decision. The trial court may go different ways. The case, when I last looked a few weeks ago, was still in pretrial motion session, but it's still a big shift from what we had seen in the past. And so what we're seeing, and this is similar to what we got from the First Circuit in Lowe, is instead of courts dismissing challenges at the summary judgment stage, they're now sort of saying, well, you know, these comparability issues, we got to have a trial. So we don't know what's going to happen at the end of the trial. And if I wasn't clear about that, I apologize.
Helpful for the clarification. And then one other question that folks asked, which religions believe vaccines violate the tenets of their faith? And is that the way you would pose the question here?
Well, I am no theologian and I am no expert in religions. So, you know, I will say just a few things. None of the major religions, major meaning lots of people, I'm not making any theological comparison, but none of the large population religions oppose vaccines. There are some smaller denominations which have questions, although some of their questions about vaccines, even in Christian Science, are more nuanced than people might think. But what I want to emphasize is, again, it doesn't matter, right? So so Roman Catholics have questioned, many of these free exercise challenges have been brought by Roman Catholics who object to the COVID vaccine because they believe that the vaccine was made with abortion, the cells of aborted fetuses. And it doesn't matter that church authorities disagree by and large. The Pope supported the vaccines, right? That's not the issue, right? And I would say we don't want that to be, right? We don't want the country to, our courts to impose a sort of canon law theological test. You're only allowed to believe, what the hierarchy of your religion believes. So it's an individualized analysis. The problem with that is it really does open the door for people whose objections to vaccines are not bona fide religious, people who may be have political objections, who might have ideological objections based on freedom or health fears, all kinds of other objections. And often it's a murky mixture, right? To rely on religious exemptions, because it's very hard to prove someone is not sincere. And again, the fact that, their congregation, their priest, their pastor, their rabbi, their imam says vaccines are fine is really not relevant to the inquiry.
Right. Okay. And I know we're not going to have time to get to all of the questions here, but I do want to get a question in for both Maggie and Katie. Do you know, someone is asking about whether the 2023 vaccine bills include provisions that were inserted into unrelated bills? For example, state budget bills looking to reduce vaccination requirements for college students.
So I'm going to give the unsatisfying answer of it depends. So the way our system kind of identifies legislation, it happens at each stage of the process. So like when a bill is introduced or amended. So if it comes up in an amendment, we'll get it so we can be able to flag that, but it's not necessarily consistent. So for example, if you're looking at something in a budget bill, it might not specifically say immunization or vaccine. So that's something where we would rely on kind of our state partners and the advocates and professionals that are on the ground that are tracking this closer, then they're often really good at saying, this is what we're seeing. And then we're able to kind of scoop it in.
Katie, anything else you want to add on that one?
No, that's it. We just take advantage of Maggie's team's great work to inform the data sets that we're building. So really appreciate
And whoever asked the question, we're totally open to you reaching out and flagging things for us. So thank you for asking the question. I think at this point, we're going to turn things back over. Thank you, everybody. Thank you to the panelists. It was a great discussion, really helpful, I think, for folks in the audience. And if folks didn't get their questions answered and still want to interact with any of the presenters, feel free to reach out to the Network for Public Health Law. We'll get you connected and we'll get you answers. Okay, Daniel.
Yes, thank you, Darlene, for moderating this great webinar today. As a quick close, I just want to invite all of our attendees to attend our Public Health Law Conference this October, the 24th through the 26th here in Minneapolis. We have 5 amazing tracks. I know Darlene is presenting, and I know a lot of other really great people in the vaccine space will be there. And so if you just follow the link down below, you can go up to sign up and register. But then other than that, I just want to remind everyone that you will be getting a copy of the slides and a recording, usually about 5 to 7 days after the webinar, because it takes some time to process and get those uploaded. But once those are up, you'll be receiving an email with a direct link to both the recording and the slides. So you shouldn't have to worry about that. Other than that, thank you all for attending, and we hope to see you next time. Thank you.